So Dr. Jason Jedlicka is a clinical professor at Indiana University School of Optometry and the director of the Cornea and Contact Lens Service. He is a diplomate in the American Academy of Optometry's Cornea Contact Lens and Refractive Technology section, a past president of the Scleral Lens Education Society, and a fellow and board member of the Contact Lens Society of America. He has contributed to multiple textbooks as an author on the topic of GP lenses. He was awarded the GPLI Practitioner of the Year Award for 2021 and the Scleral Lens Education Society Scleral Practitioner of the Year for 2023. So thanks again for being here with us tonight. There are financial disclosures which have been mitigated. So I'll let you take it away.
All right. Well, thank you, Dr. Kramer. And I apologize for the echo a little bit ago. I hope we're good to go. Welcome, everybody. And thank you for being here. I don't know if your day is quite as perfect as mine is, but it's a beautiful day here in Indiana. And I've been enjoying participating in this from sitting out on my patio today, but I had to move indoors, of course, for this to keep the noise down. So pleasure having you all here. It's great to be here, and it's quite an honor to be part of this highly esteemed group of speakers for this weekend's program. This is really an amazing lineup that we are getting to take in, and I'm thankful to be participating. So again, welcome. The topic for this hour or so is finding the right fit, a comparison of scleral fitting techniques. And I've got my disclosures again. And just wanted to kind of introduce what we'll cover here in this section. We're going to talk about scleral lens fitting, so to speak. And what's interesting, of course, is that when we have a lens on a patient's eye, no matter how we arrived at that lens, we're still kind of doing the same thing. So when we talk about scleral lens fitting and the differences in the different techniques, it really boils down to this. It's how are we arriving at that first ordered lens that we are putting on our patient's eye, whether it's dispensable or not. It's, we've done some work. We've either put some diagnostic lenses on, we've taken some maps and used those maps to create a lens, or we've taken an impression of the eye and we've made a lens from that perspective. And then we've ordered that lens and then we dispensed it. We put it on the patient's eye. And to that point, there's a variety of different ways we can get to that point. But once we get to that point and we've actually got the lens on the patient's eye, that first lens, then it comes down to our skill as fitters and how do we recognize the issues with our fit? Because no matter how you go about it, you're always going to have the potential for modification, right? Because the eye it's not made of stone. It changes. And so what we see one day may be a little different another day. And so we may do our very best one day to get a great looking fit in our perspective, and then we dispense it and find that it isn't perfect. So we'll talk a little bit today, a little stroll down memory lane, how we got to where we are in 2023 when it comes to fitting scleral lenses. We'll talk a little bit about the different ways, again, of arriving at that first ordered and dispensed lens. And that's really where the differences occur and how you go about that process. And then I'll finish by just talking a little bit about some of the different ways that we can improve our diagnostic fitting techniques going forward. And also when we look at those lens fits, how do we assess our lens fits for further modification? So hopefully this will be helpful. So what are our goals when we fit scleral lenses? These concepts have really not changed. Now there are some interesting little ebb and flow in the process. The whole idea of fenestrated versus not. It used to be fenestrated and then fenestrations kind of went away. And now they're kind of coming back a little. But ultimately, the whole process is essentially the same goal, and that is to create a lens which couples to the anterior ocular surface in a way that a fluid reservoir is held behind the lens, and that lens then vaults the cornea by a given desired amount, and that can change based upon the patient. The lens then vaults or at least doesn't compress on the limbus, and then it lands nicely, as evenly as we can get over the sclera, over as much surface area as possible. And that's always been the goal. And that still is really the goal for 99% of our patients. So again, diagnostic fitting versus advanced techniques. And we talk about advanced techniques. I'm going to talk about instrument aided fitting, which is when you allow some type of scleral topographer or what have you educate your process so that you are more efficient, but you're still doing the fitting, versus instrument fitted lenses, where the instrument actually does all the work and you're just kind of along for the ride, offering a little bit of advice, if you will, all the way then to, again, our impression-based lenses, where, again, everything is done strictly by the impression and the software that derives the shape from that. So again, the difference in all these is really how we get to that first lens order. How do we get from the beginning of the process to putting that first lens on it? Once we get to that point, it's all about just our skill in adjusting fit going forward. So let's talk about diagnostic fitting. I can recall many years ago, early in the process for me of fitting sclerals, which started in 2003 maybe, that I had a consultant from a lab come to my office and brought a fitting set of scleral lenses, and I had set up 4 or 5 patients to fit. A lot of us have gone through this process with a lab before, and we brought in the patients, and the consultant took a look at the patient and got alongside them and had them look straight ahead and pulled their lids apart and looked at their eyeball, just like you kind of see in these pictures. And he looked at the eye and grabbed a lens and put it on, and he literally just eyed it up. And that side view of the eye gave them the information that they knew about how much depth they needed and what kind of shape they needed. And so, the old days of scleral lens fitting was literally just using your ability to look at an eye shape in side view from perspective, and understanding that, grab a lens from the set and put it on. And that was really some of the beginning points. Similarly, our first diagnostic sets were fitted a lot like just like corneal GPs. You see here a given set of lens parameters, and even modern lenses essentially to an extent work the same way. They're a series of curves or things like that, but how we go about determining those curves and deciding what they are, we don't necessarily do it by virtue of ordering a certain base curve and a second curve and a third curve, radius and width. A lot of this is already in the software that's going to make that lens. And all we really are looking at now is we're really driven towards the elevation part of it and how much clearance we need, clearances more than anything. And then we just trust that the design software that makes that lens is going to generate those clearances the way we want them to. But again, you can still fit lenses this way too, based on base curve. And as you would go through your diagnostic set, steeper base curves would have more sagittal depth. So if I grabbed a lens from my diagnostic set that didn't have enough clearance and I needed more clearance, I would just strictly grab a steeper lens base curve, and that would give me added depth. No sag data. I remember some of the early sets saying, can't you put the sag information on my invoice so I know exactly how many microns of depth? They said, well, we actually really can't do that because it's not part of the software, and it's not, we're not able to put that parameter on there. Okay, so obviously a lot of that has changed now. And so again, as we've evolved through moving towards a kind of a different mentality of thinking away from base curve, away from curve widths and radii to just clearances and heights. I remember years ago I'm at a school, I'm at the Indiana University School of Optometry. And I remember many years ago talking to a lab manager about the idea of again, referring to scleral lenses more off of sag values than base curve, because I thought it just made more sense to work off of elevations and clearances rather than curves, when ultimately our goal is to generate a certain depth to a lens. And at the time, that lab manager said, I don't think you're going to get practitioners to be able to change their mentality of thinking from curves and widths and radii to sag and elevation. And then just, a few years later, sitting in a classroom, I had one of my students ask me when it came to modifying a corneal GP, if we were touching the apex of the cone, does that mean I need to add more sag to my lens? So the transition to sag-based thinking, elevation-based thinking, I think has happened for all of us who do this. I think our instrumentation helps that. Our scleral topographers have evolved us into thinking about elevation again, rather than curvature. In some of our earlier designs, diameters were available, different diameters were available, but I think in some ways the diameter options were a little bit haphazard and they didn't really correlate to anything meaningful with regards to how we fitted lenses all the time. We knew that there was this area in around 18 millimeters that was a common diameter for scleral lenses, for a full scleral lens. And so I think that was just kind of where we were, and everybody thought, well, that's typical, that's where we need to be. And then the idea of a mini scleral coming along, going smaller, and again, how did we arrive at those diameters? Again, I think maybe a little bit arbitrary, but I think as our fitting techniques have evolved, diameter means something. Increasingly, it means more than just what's the overall size of the lens. It means how much of that lens is designed to clear the cornea and limbus, and how much of that lens is designed to land on the sclera. And that's important. It's important to get a good fit. And it doesn't mean that you have to necessarily fit a certain diameter lens on a certain diameter cornea all the time. But it does mean that if you decide to go to a larger lens, let's say on an eye, how do I want that increase in diameter distributed? Do I want it distributed more in my vaulting chamber part of the lens, or do I want more of that increased diameter in the sclera, in the landing zone? And I think that's important to think about. I think that, again, a scleral lens that extends too far beyond the limbus before it touches down and then has too little of a landing zone from there, there's issues with how that fits. And so I think we need to have a ratio of how much lens we have in our vaulting chamber, how much in our landing zone, to produce optimal fits. Again, over time, as I said, some of those first diagnostic sets, it was all about base curve. And so when we needed more depth, we went to a steeper base curve. Well, that's great. If my cornea is also steeper, then that makes sense. But what if I have say a corneal graft that's very deep, but centrally is actually quite flat? How do I cope with that type of a fit when my lens is increasingly steep to get more depth? So again, the thinking of needing different geometry options became more common. So fit sets evolved options with having prolate and oblate shapes within the same fitting set. And so just like if we were fitting a specialty corneal GP on a LASIK patient, post-LASIK patient or post-RK patient, I wouldn't reach for the same fitting set as a patient with keratoconus. The same really is true of sclerals. And so our fitting sets became outfitted either with secondary sets for reverse geometry, or within the set, we incorporated both reverse geometry and standard geometry lens options. And then, of course, we understand now that the eye itself, the sclera, the cornea, there's just a toricity built into the anterior eye. And that toricity can, again, happen in the cornea. It can happen in the limbus. It can happen in the sclera. And the scleral and the shape of the sclera, the toricity of the sclera can be different than the toricity of the cornea and limbus. So, we're gaining more understanding of scleral shape. As we do that, we evolve, again, our thinking from primarily scleral or spherical scleral lenses, which I think was all I fitted for the first 8 years of fitting scleral lenses for me, to evolving to fitting almost everybody in some degree of toricity, to now, increasingly using quadrant specific or lenses with toricity internally, not just in the haptic. And so our utilization of putting toricity and quadrant specific curves in our lens is growing as our lathing capabilities and software improves, as our understanding of eye shape through scleral topography improves. we see the benefit, we see the need, and it becomes reality for our manufacturers to offer those options. So fitting sets went from mostly spherical to now where many of our fitting sets, even our diagnostic sets, have toricity built in. So the early techniques of fitting scleral lenses really required that the fitter have a good instinct or, a gut for the shape of the eye, and could look at an eye, just eye it up and be able to understand a lot about that eye. What a large cornea and a small cornea meant, different shapes, things like that. And it was more trial and error than science, because we didn't have the capability of doing it scientifically. We didn't have measurements of the shape of the ocular surface in any meaningful way to allow us to be scientific about our approach. We had to do trial and error because that's all we had. And we could still be very successful at that. I still think that fitting out of a diagnostic set, even without a corneal topographer, you can be successful at an extremely high rate, 90+% of the time. You can be successful with just basic diagnostic fittings without even a scleral topography, but it is going to take you more time, and it's going to take more trial and error. It's going to be a little bit more laborious for the patient as well. And so, again, I think that in a beginning process for a lot of fitters, this is a good way to do. And you need to build your own personal skill at fitting anyway. And in many ways, diagnostic fitting requires you to develop that skill. And even as we evolve into more advanced fitting techniques with more sophisticated designs, ultimately you still have to know how to make adjustments to that lens when it's not ideal. And so, going ahead and doing a lot of diagnostic fitting is a good technique. It's a good practice for developing skills, and there's nothing wrong with that. It really does help you understand and start to get a feel for the ocular surface shape the more you use diagnostic sets. Again, even without the technology behind it, our understanding of how to fit has evolved. Even without having sophisticated measuring techniques for ocular surface shape, we can see when we need toricity just by putting a lens on, right? We always say that a GP lens with fluorescein is your best topographer, right? So when you put a GP lens on an eye, whether it's a corneal GP or a scleral, whatever, and you've got fluorescein under that lens, you should be able to derive an understanding of the shape of the eye underneath that lens, whether there is toricity there and where it's located and all sorts of things. The shape of the eye, whether it's steep or flat, et cetera. All these things we've learned even without having the sophisticated technology. Now, the sophisticated technology helps fast forward and advance our thinking, but we've learned a lot of that already. And so even before all of our advanced techniques and our advanced instrumentation, we were already understanding the need for having different diameters in our fitting sets and different geometric shapes and adding toricity in different places and things like that. And so, again, we are evolving in our thinking, whether we have the technology or not. We're getting better at it. And even diagnostic fitting with a fitting set alone is evolving in its technique. And so this is something that is definitely happening. We can still be very successful, again, even with basic diagnostic fitting sets for the vast majority of our patients. So again, I kind of lumped this into 4 different categories because I feel like this is my perspective, how it happens. We've got our basic diagnostic lens fitting, and that's a situation where the practitioner has maybe corneal topography at best, but that's about it. You have no advanced technology to enhance your thinking of how you're going through the fitting process. Then we can get into instrument-aided diagnostic fitting, which means I've got topography, I've got information, I understand about the shape of the eye, but I'm still going to diagnostically fit, but I'm going to do it more efficiently and more effectively because of the information I have. So instead of having to put on 2 or 3 or 4 lenses, I can put on 1, evaluate it, and I can be done. A third way of fitting scleral lenses is instrument fitted lenses. And this is where the instrument and the software that drives the fitting process does all the work for you. You do have some controls where you have the ability to go in and make adjustments if you see the need. but you don't have to. And many times it's almost better not to, but to let the instrument itself have full control to start with and then modify down the road. And then our fourth technique is impression-based lenses. And I've broken down the differences as we go from left to right. We get, our lenses become often more expensive because they're more sophisticated. Because when we go to an instrument fitted lens or an impression-based lens, we can do things that we can't do with a diagnostically fit lens or just an instrument aided diagnostic fit lens. We can make more complex curves. And so the fact that they cost more makes sense because they take longer to make. And that's the way it should be. From our perspective as fitters, these more complex lenses that are more expensive save time because we can often fit more complex eyes with a simpler process than our diagnostic fit process. And they can be more convenient for patients as well. Not only do they take up less of our chair time, they take up less of the patient's time. On the opposite end, of course, our more basic diagnostic lens fitting, while it can still be very successful, tends to be less expensive, which can be a benefit to some patients, is more time consuming both for us and our patients. So we should recognize that. Diagnostic lens fitting 2023, how one would go about this process. Again, I think, as we as specialty lens fitters or specialty lens fitter wannabes, we have to understand things about the shape of the eye that go along with our skill as fitters. We need to understand the difference between how we approach a larger cornea and a smaller cornea. That hasn't changed. And we need to understand the designs we're fitting. We need to know if we have a diagnostic fitting set and that's our bread and butter fitting lens that we use. We've got to know the ins and outs of that design. We've got to understand it right, to the core to understand how those curves are built. So that when we put that lens on and we need to make adjustments, we know where those adjustments are going to occur. We also need to understand the shape of the eye, the geometry of the eye. It is important. I realize that when we're fitting an eye, a scleral lens, we're vaulting over that whole thing. I get it. You say, well, what difference does it make what the shape of the lens is? The difference the shape of the lens makes is that if I want to have a specific amount of vault, and I should have a desired amount of vault, and that might be different in a patient who's a cone and a graft. Okay. My cone patients, I worry if that cone progresses and that apex touches the back of my lens, do I develop contact? I may want to fit my cone a little bit deeper with more vault than a graft patient, where I've got a fairly broad central area of the graft. And so if by chance I touched, it's not going to be focal, but I want less vault because I want more oxygen to that cornea. So my approach is going to be different for each type of patient. At the end of the day, though, is I don't want excessive or inadequate clearances over any more of that lens than I have to have. So if I have a patient who's got a steep cone, I want a fairly steep base curve lens. I still want to somewhat mimic the shape of that eye, because if I don't, I'm either going to end up with too little central clearance or too much clearance in the mid periphery, which is going to affect the fit and the health of the cornea underneath it. So I still think it's important to relatively match the shape of our lens to the shape of the cornea we're fitting when possible. Again, understanding the eye shapes. This is a chart I use when I teach in our classes, our advanced contact lens class, how to think about things. And again, I think, we think about eyes as deep to shallow, and we think about eyes as prolate to oblate. And you may not agree with how I've categorized everything here, but as you go through in this chart and you think about what constitutes a deep eye, to me, the deepest eyeballs I ever see are post-graft eyes, right? It's because we've removed cornea and we put a new cornea in its place that's bigger. And so, of course, we're going to add depth. And so the post-PKI to me is the deepest. When I've got a post-graft eye, I know I need to be working in a deeper part of my fitting set. As we move through the things like advanced central cones, central nodules that push forward in space, things like that. I need more depth. As I move across the grid here to my post-refractive patients, particularly post-LASIK, I'm increasingly getting shallower and shallower lenses. In terms of shape of the eye, again, the most prolate types of eyes are those advanced cones that are very central. This really steep nipple cones are going to be most prolate. And at the other end of that spectrum, again, our post-refractive patients are going to be most oblate. So as we go through and we think about the geometry of the lens we need and the depth of sag the lens we need to pull out of our fitting set. So you're sitting there facing a patient and you say they have this type of eye, then I need a lens that has approximately this kind of depth and this kind of shape. That is going to drive your thinking and your fitting set to narrow it down to maybe just one or two or three best options within that fitting set. And so this is the thinking process that should educate our diagnostic lens fitting as we begin the process of initial lens selection. And of course, this part we should all understand, but diagnostic fitting requires that you're probably going to see more problems because you're going to be less accurate with that first lens. So if I'm just going off my intuition and putting a lens on, the odds that I'm going to see a central touch, like I see on the left here, are greater than if I've used instrumentation or something to educate my fit and drive me to hopefully a better fitting lens. So like always, we look at our initial fit and we decide we've got to go deeper, shallower. We move through our fitting set looking for a lens that's going to have that right amount of depth. And again, lens sets today are going to be labeled with depth to help us through that process. When we assess edges, again, we're always looking for signs of toricity. Our fitting set may have toricity. We're looking for rotation. Of course, when we've got toricity in a scleral lens, we expect to find that toricity can be anywhere. In fact, scleras tend to be far more against the rule in shape than corneas. So when you find those rotational marks on your diagnostic lens and they're rotated 80 degrees, that's just fine. That's wonderful. Some people think, well, that's too much rotation. I need a different lens. No, you have a perfect lens. You want the lens to rotate where the eye wants it to be rotated to. So looking for signs of a tight edge or loose edge, make sure you're moving your light source around to look for that. Make sure you decide, do I indeed need a toric lens? Do I need a spherical lens? Do I need more or less toricity? And then, over refracting, I like to always over refract and look for toricity. That doesn't mean I'm going to prescribe it. I think it's helpful because if you put a lens on the eye that is under toric, okay, so again, let's say the patient has 300 microns of toricity and you put a diagnostic lens on with 150. It may rotate nicely into a place where it looks like it's pretty well locked in, and you may not see a ton of indication that you're way undercorrecting or overcorrecting their cylinder. But if you over refract and you find toricity that matches the axis of the rotation of the lens, you know that you are undercorrecting their toricity in their haptic, in the fit. You've undercorrected from a fit perspective. And so that will drive you to understand, maybe I need more toricity in my lens from a fit perspective. I'm not talking about a front toric to correct residual cylinder. So a spherocell over refraction can help actually with your fitting process to understand, have I added the right amount of toricity to my lens? Is it an appropriate amount? And if it's not, then I've got to reassess my fit. Of course, if you do find a spherocell over refraction, I would always hesitate to add cylinder at the initial process on our diagnostic fitting until we've really got a fit that we're happy with and we're close. If we've still got residual cylinder after we feel like we've got the fit pretty well optimized, then by all means, go ahead and add that cylinder later. So again, diagnostic fitting is really pretty straightforward. It's you've got a fitting set and you're going to find the lens in that set that's closest to optimal. And once you've discovered it in your set of 15 or 20 lenses, once you've found it, there's nothing more you can do. You've found the lens in the set you're working with that is the closest to the best lens for that patient. Great. Over refract it. look at it and figure out what else do I need to do to adjust this fit. Do I need to increase or decrease toricity? Do I need to increase or decrease sag? How do I overfract, et cetera? And that's diagnostic lens fitting. Now, again, the problem is you may find yourself in a spot where you're actually pretty far away from that ideal fit still, but with a diagnostic fitting, that's all you can do. So you order that first lens, and now you're done with your fitting. You're now on to your modification process. So again, there are some advanced techniques I like to talk about and go through, and these are fun. These are exciting things to do. Do we need to do them on every patient who comes in for a scleral lens? Probably not. But are there patients who definitely benefit from advanced techniques in terms of getting a better fit? For sure. Are there patients or do our practices potentially benefit from being more efficient? For sure. Do our patients benefit when we are more efficient? For sure. So there are benefits to moving into advanced techniques, especially once you feel like my volume of scleral lens patients is going to be sufficient to move that way. So when we talk about instrument-aided fitting, and I will say this, in my practice, I've got instruments. And so I almost never fit truly basically diagnostically, because why would I if I have instruments to aid my fitting process? But that said, I do instrument-aided fitting the vast majority of the time because it's still most cost-effective for my patients. And as long as the eye I'm working on is not too unusually shaped, if I don't have a huge filtering bleb or something on the eye or a tube shunt I'm trying to work around, if I've got essentially a basic, normal, irregular cornea patient eye, most of the time I can get by with diagnostic lens fitting. But if I have an instrument, I'm going to use that to aid my fitting. It would be silly not to. So the instruments that we have now can provide important things like it can give us, given a diameter, if I know I want to fit a lens out of my fitting set that's 16 millimeters, I can put that diameter into my topography software. It will tell me at that given diameter what sag I should use. It will tell me how much toricity I have in the shape of my eye at that core diameter. And again, the diameter selection can come based upon the information. As you can see, the map tells me my white to white value. So my instrument can guide my selection of the diameter of lens I want to fit. It can guide the shape of the lens I want to fit, whether it's oblate or prolate shaped. It can guide my sag selection so that when I do grab my diagnostic lens fitting set, I grab the best sag in my fitting set 90+% of the time on the first try. It also tells me whether I have enough toricity in the shape of the eye that I need a toric haptic or whether a spherical haptic is preferred. And again, all those things just add to allowing me to be one and done with my diagnostic lens fitting. And that is impressive to the patient when you can pull a lens and put it on and right away they say, hey, that feels pretty good. And you look and say, yep, it actually fits pretty well the first try. That's impressive. And so that creates a positive feeling for your patient working with you on this, and they gain confidence in you. And that's not something small. It's important our patients feel confident in our skill and our ability as fitters. So again, what can our scans tell us? They can tell us, in this case, I've got a white to white of 12. That tells me I right away have in my mind what diameter lens I want to fit that patient, and based on 12 millimeters and based on knowing the condition I'm fitting, whether they're a post graft or a cone or whatever their condition is. When I know their condition and their white to white, I know in my head generally what diameter lens I'm fitting, because the lens I'm fitting may only come in 3 or 4 options of diameter. And so given my white to white and my options I have, I will pick the appropriate diameter lens to fit. Again, I can then put that diameter into my instrument. It will then tell me at that diameter the sag I need and it will tell me the amount of toricity at that chord length. So it allows me to, again, grab a diagnostic lens out of my fitting set that is the right diameter, the right sag, and the right toricity for that patient, given what I have in my fitting set to work with. So again, a one and done situation as far as diagnostic fitting is a lot better than a 2 or 3 or 4 lens and done process, which is laborious for our patients. So that's the idea of instrument aided fitting. It is the same process as diagnostic fitting, but it is, instead of just using pure intuition and grabbing a lens from my fitting set that may or may not work well, or may or may not be the best lens in my set, it allows me, with the time it takes to get a scan of the eye, to then pick the best lens out of my fitting set the first time, 90+% of the time, and make that process extremely efficient for both me and for the patient. But there are times when we've got more complex eyes and we need the instrument to get more involved in the fitting process. And so that's what we'll talk about now, our instrument fitted lenses. And I broke this down into 2 categories. We have entry level and advanced. And so entry level instrument fitted lenses are the instrument is giving you all the parameters you need without having to put a diagnostic lens on, but it's a far more basic rudimentary algorithm for that. And you're basically just getting lenses, again, that you could get out of a diagnostic set. And so when we go through a process like we look at here, where we choose a lens based upon our topography, we go to our first lens fit, and it gives us options. We choose the lens we want to fit, et cetera. We still have to think about the lens we want to fit. We have to think about the diameter we want to fit. And then we let the instrument give us, again, the sag, the toricity of each of the quadrants, for example, specifically, and so on. And if we trust our map well enough, we could go ahead and order that, provided we already knew the prescription parameters that we were going to need. Maybe that patient's come out of a GP already or a scleral already, and we know the base curve and power of their prior lenses. And so we can create a base curve and power combination that we know will work. This is an approach, again, an entry level, kind of a rudimentary approach to instrument fitted lenses, where we let our instrument do all the design work, and then we just simply order that lens from the lab, either by calling in the parameters or by sometimes using a link between the instrument and the lab. Now, there are more advanced techniques for instrument fitted lenses, and I would say that in general, this is when I want an instrument fitted lens, I generally want it, for me, because I want something more advanced. If I want a basic scleral lens and I have an instrument that I can use to gather the data, I generally would prefer to put a diagnostic lens on and just double check everything to fine tune it. But there are some instances when I know that my diagnostic lens fit isn't going to give me much helpful information because the eye is very irregular, or they've failed out of something more basic, and I need to move on to something more sophisticated with more quote unquote free-form options, because we need that lens to have some unique shape qualities that a diagnostically fitted lens just has no chance of having. And so in those situations, we're using our instrument, as we see in the picture on the left here, our scleral topography, to then input that information into a software program that has very sophisticated capabilities for creating a very customized and free-form lens for our patient. And you can see by the picture on the bottom right, the complexity of lens that you can create using an instrument-based map through these software programs that integrate with them. There are a variety of different instruments that we can use and different softwares we can use. There are some that are integrated with all of the different topographers. This is another program that has capabilities where we just essentially take our scleral map, we import it into the software, and we allow the software to do the design. And again, in many cases, you're better off letting the instrument do the full design process first and just see what you get. Now, there may be situations where you have an understanding of the eye and some history that may impact what you allow the instrument to do. What I mean by that is, for example, in this case, we've allowed the software to create a lens, and it's chosen for us a 16 millimeter diameter. If you look in the upper right, near the little star, it says OAD 16. Well, maybe I know, given the history of this patient, that I want a bigger lens. I can certainly override that and change the diameter to anything I want. If I want to change it to 16.5 or 17 or whatever, I can override that, and I can go ahead and change the diameter, and then the instrument will recreate the lens to be optimized for shape at the diameter that I've now asked it to create the lens in. So again, you still have control. You're not giving over all control to the instrument, but in many cases, you're better off letting the instrument make the bulk of the decisions, because it's doing things in a free-form way that you don't have a lot, that you probably can't do better even if you tried. All right. Oops, sorry, back up. And this is just a picture. These are just simply pictures of instrument aided, driven, first time out of the box, order the lens based off the topography, put it on. You can see by the picture on the left, this is a really nice fit. You can see the picture on the right, the vault looks about right, nice and even, 300, 350 microns, whatever. A very nice capability of creating lenses based upon the maps. And of course, like anything that's map based, right? It's only going to be as good as the map that you're giving it to work with. So do make sure that if you're doing an instrument design lens, that you put the time in to ensure that that map that you're feeding into the software is as good as it can be. It's as reliable and predictable. And a lot of times we'll repeat these maps 3 or 4 times. Not if I'm just doing an instrument aided fit. I don't need it to be quite that accurate. But if I do want that map to drive the entire design process, I'll often repeat them 3 or 4 times till I want to make sure that that thing is spot on. I want to make sure it's truly representative of the eye that I'm trying to fit. Here's another type of lens. Software, again, integrates with different topographers. Some of these software programs are proprietary to the labs, and some are to the instrument. And in this case, there are instrument fitted software programs that are tied to the labs, and they integrate with the instrument. And so the instrument takes the map, you then upload it to a software or cloud software location, and then the lab that's going to make that lens for you takes that map and creates their design. And so again, this is another software program. We upload our map, and it walks us through a 7-step process or so to create that lens. Again, giving you as a fitter the ability to have some adjustment factors. If you know, I want a diameter of a certain size, or I know something about this patient that I think is helpful to guide it in a certain way, and the software gives you something that disagrees with your thinking, you have the ability to modify that. So again, you're uploading your topography. On the upper left, you can see the eye is uploaded to the software. We verify the location of the limbus, for example, and then we simply allow the instrument to understand the shape of the eye and create the set of curves that it feels will best contour to that eye. Again, you can set things like your preferred amount of vault, your preferred amount of limbal clearance, et cetera, et cetera. So if you say, well, in this case, I think I want a little bit more vault or a little less vault or whatever, you do have that capability in the software to adjust those things, but the instrument is still going to give you the best lens it can give you based upon your preferences and your presets. Again, another example, some of these programs can be very sophisticated. You can take a very complex eye and you can create a very unique, uniform, free-form lens for that eye. And then once that lens has been ordered and dispensed, this gets back to this whole modification process. I said before that, the whole process that's different is getting to that first ordered lens. And that is true. Once we have a first ordered lens, it's all about understanding the eye and making the right modifications. But how you make those changes is different, whether I'm calling up a consultant and telling them what I need, or whether I'm going into a software program and I'm making adjustments within the software to change the lens in a way that I need. Ultimately, it's still you making those calls, but it's how you communicate that information to the lab. So again, these, and here's a picture of a patient in a software-driven lens that you can see where the red arrow is pointing there. This is a very large filtering bleb on this eye. And again, the instrument, given a really good map, is able to create a lens that will vault up or fit over properly something as complex as a filtering bleb. It's getting, again, more sophisticated, more capability of doing very unique design attributes. And then, kind of the end of the line here, the pinnacle of the most, complex and most individualized fitting really is the impression-based lenses. And these are truly amazing to see how they can be so beautifully matched to the shape of the eye. And it's really just a price point thing, right? I mean, if these lenses were a tenth of their cost, we would do them at everybody. So, we do tend to reserve these for those patients who the cost is warranted because they have an eye that we know will be very time consuming to fit any other way, even if we can even get a successful fit in that way. But impression-based lenses are certainly have produced amazing fits for eyes that you would initially look and think there's no way I'm going to get this thing to fit well. So that's just kind of a quick summary through the fitting techniques and how you go through the process of, do I diagnostically fit? Do I want an instrument to help me? And again, I think based upon your volume, that's something that you need to decide. Do I invest in an instrument? Because an instrument will allow you to be more efficient. And so you say, well, am I going to make money by billing these maps? No, you're not going to recoup the cost of a scleral topographer probably from charging the patient or their insurance company for scleral topography. You can't think of it that way. You think of it as a chair time saver. You think of it as a practice building thing that with this instrument, I can do more. I can impress my patients. I can be a better fitter, and therefore it builds my reputation, it builds my referrals, et cetera, et cetera. So, but the other part of having that instrument, other than just being a more efficient diagnostic lens fitter, is it does allow you to have the capability of doing instrument fitted lenses when you need them or when you feel like they're warranted. So when I've got a situation where I've got a more complex eye, it allows me to have the software to do a more complex design. So having an instrument can be a benefit to your practice as well. The last few minutes here before we wrap up, I just want to go through a couple of updated techniques. My thinking about how I think a scleral lens is changing a little bit. My thinking about a lens design, there's some terms that I like to use. I'm really using the term vaulting chamber a lot, and that's just the part of the lens that doesn't touch the eye. And that's a critical component of our lens fit. And the rest of the lens, of course, then is going to be our haptic. But differentiating that internal and external landing points, as well as the vaulting chamber, are important things to think about as I go through our fitting process. And then we've had this concept of our heel and toe, on our edge. And I think that's valid. And it's, we want a edge that lies down nicely with the heel and toe both in alignment. We also want to contemplate the idea of the knee of the lens. I think we're going to find as we go forward more and more lenses that are being built with internal toricity capabilities. I know that's absolutely happening. I think that getting the entire heel and toe of the lens to fit to the eye shape completely requires internal toricity to bring that into fruition. As you go through your fitting process, I hope you already do this, but please use fluorescein. If you evolved your fitting to the point where you thought you didn't need it anymore, you need it. You just don't know you need it. But really use the fluorescein and evaluate the fit of your lens carefully. Move your lens. If you're not, pushing that lens around every time you see a patient with a scleral on, if you're not moving that lens up and down, left and right a little bit, just nudging it here and there, you should be, because moving that lens around tells you things. If you looked at the picture on the left, you might say, well, I have too much toricity or I have too much clearance inferiorly. I might be touching superiorly. What does that mean? I don't know. But if you center up that lens and look, you say, oh, well, now I see I have an oval shaped fluorescein pattern, and I have poor heel alignment in my vertical meridian. And so I've got to do something to bring my heel down into proper position. So using the dye, getting involved, getting in there and moving that lens around and looking at it is important. At the same time, I think it's critical, especially if you are inclined to use OCT a lot in your fitting process, that you do not have the patient looking in various fields of gaze when you do your OCTs. If you are, you're only getting valuable information in that field of gaze, and the patient probably isn't in a peripheral field of gaze very much in the course of their day. So do try to keep your OCT images of the patient only in primary gaze. If you want to have them look up, down, left, right, that's fine, but you shouldn't be basing a lot of your fit decisions upon when the patient's looking into secondary fields of gaze. I love the idea. I don't know how many of you guys are ortho K fitters. I've been doing ortho K for longer than sclerals. And I think that in a lot of ways, the ortho K fitters of the world are further along in their thinking. And so they understand better how we need to do our different types of fits. So moving on, just wanted to wrap up again. This is an ortho K fit on a patient with lots of toricity. And I would just wrap up and say, again, if you have ocular surface shape data, use it in your fitting process whenever possible. If you don't, use fluorescein, and that fluorescein pattern can be your skill. So again, just want to thank you guys for being here. If there's any questions, again, I can take them at this point.